We'll talk about some of these common injuries. Some of these, most of these are traumatic injuries, but some common things we see also that are not traumatic, like our overuse syndromes. So we talk about our anatomy of these joints. Just think about the importance of these ligaments and these supporting structures. So here in the elbow itself, the ulnar collateral ligament is really important for stability of this joint. It's what really stabilizes that joint and allows us to have good fluid movement. So if a patient has an injury or we're worried about an injury to the UCL, that can definitely cause some instability to that joint and cause it to be weak and not have a lot of adequate movement. We talk about the base there at the distal forearm, there at the wrist. We have this membrane here that connects these, and one thing you'll hear when we talk about lower legs, if we haven't already, is that we have this membrane that connects anytime we have the paired bones. So we're talking about the forearm or the lower leg. Anytime those paired bones are there, they're connected in at least two places. And so definitely if I have an injury to one area, I'm more likely to have an injury to another area as well. The forearm itself, we used to talk about these deep versus superficial structures or even having different compartments there that play a role with either flexion or extension. And it's not as common, but since we got multiple layers here of muscle and fascia, this area is at high risk for compartment syndrome also. So anytime I have these complicated fractures, I've got tissue trauma, I've got edema, I've got bleeding, definitely have to have that suspicion this person may be at risk for compartment syndrome. We think about that a lot, mostly with the leg, but definitely the forearm can be a source as well. So we talk about general orthopedic things, and you've heard this before, and you'll hear this again, but anytime we're talking about joint problems, always make sure we assess the joint above and below, and especially we're talking about imaging, that's really important as well. And we're talking about those paired bones, we're talking about the forearm or the lower leg. If I've got these paired bones, making sure I see all of those joints. Because if I have an injury to one, I'm more likely to have an injury to the other. Really good rules for any type of orthopedic problem is get a good assessment of their neurovascular status before and after any manipulation, and definitely before we discharge those home. Because if they have a decreased pulse or they have some decreased movement, I would like to know that it's there before I started manipulation versus afterwards. So making sure we get that good assessment before and after and document that very well. If we're doing some immobilization, have we taken precaution to prevent further injury? Have I addressed any skin injuries that's underneath that? Have I done adequate padding? Do I do good education of the patient of understanding of how to take care of this splint or this cast properly? For most things that we do, we're going to use splints initially to allow for swelling, and that reduces the risk for things like compartment syndrome. But making sure we do really good education of the patient or whomever the responsible person is going to be to making sure they take care of this properly. And definitely, anytime I'm concerned about some type of neurovascular problem, let's get our experts involved sooner versus later. Whether we can assess this with physical assessment or maybe using Doppler, or we're having to go to advanced imaging like CTA, get an idea of those and address these sooner versus later. So the elbow, commonly injured areas, that a lot with falls, blunt trauma, but who needs an x-ray of this? And one thing they've looked at is, can we kind of reduce the number of imaging and hopefully reduce length of stay as well? But if I've got an injury to the elbow, there to the olecranon, and somebody can lock that in full extension, and that doesn't give them severe pain and they're able to do that, most of those patients probably do not need any imaging of the elbow, of the olecranon, or that proximal area there, the radius. So something maybe to use in practice to kind of get an idea, where are they point tenderness at? Is it right there over the olecranon, or is it somewhere else there in the joint space? But if they can lock that in full extension, most of those patients probably do not need any imaging and a supportive care. Look at our fat pads. We talk about fat pads a lot with our pediatric patients, but even sometimes these can help us with adults as well. So anterior fat pads we'll sometimes see, and those can be small and be normal, but posterior fat pads, we always consider those to be abnormal. And we'll look at some images of these in just a moment, but definitely if I'm seeing a large fat pad or I'm seeing that posterior fat pad, I'm really concerned about some type of occult fracture. Maybe some type of very small fracture that I can't see well in imaging, but definitely if we were to re-image them later or get advanced imaging, those do show up. So as we can see here, I've got a nice normal anterior fat pad. It's just a little bit there outside that joint, but it's not huge. But if I look on the other side, I've got the cell sign. I've got that big anterior fat pad sticking out, but also that posterior fat pad. And even though it may be difficult to see, if you look, I do have a very subtle fracture there. But if you're seeing those large anterior or you're seeing any posterior, think about this person may have a fracture that I can't see. Get another view And usually if we're ever in concern and you don't have the resources, you're never wrong to immobilize someone and then have them come back for re-imaging with you or somewhere else in a couple of days, as long as we do good education and we talk about the risk and benefits of that immobilization. So radial head fractures, those are definitely common in our adults. We see those a lot, especially with our Fourche injuries. So that fallen, outstretched hand, we see a lot of distal fractures with that, but also a lot of proximal fractures as well. These definitely can be problematic, and especially if I'm seeing large fat pads, whether it's the big anterior or even a small posterior fat pad, that's really concerning that I have a fracture there. So get a good assessment. Where are they tender at? How's their range of motion? And one thing we have to worry about with any of these joints where I have a large vascular bundle flow through is, do they have risk for neurovascular injury? How's their sensation? How's their movement? Most of these can be managed minorly. Now, if they have a very large fracture, this is based on the Mason classification system, probably a class 1 or a class 2. Those require nothing but supportive care. But if they have a pretty unstable class 3 or up to a class 4, those almost always require orthopedic intervention and probably open reduction and internal fixation. If you have the access, share these images with your orthopedist, get their opinion, and then set that patient up for care, whether it's going to be just split and immobilized there in the ED. Some of these may just require just a sling and nothing else if it's a class 1. But again, looking at your imaging, what do I see? Get a different view. There's all these wonderful memes of looking at stuff in different views, but for most of these joints, we want those 2 or 3 views, because what I see this way may look totally different if I look this way or a little bit oblique. In kids especially, if you're not really certain, think about the importance of comparison views. I get that left elbow, I don't know if that's normal or not, then let's get a right elbow. Risk of radiation is pretty low with plain films, and definitely sometimes those comparison views can be really helpful to say, hey, is this a normal variant for this patient, or is this their normal physiology? We'll talk about the growth plates here in a moment, but those can sometimes also get confusing for some people, especially if we haven't looked at a lot of pediatric films. Our supracondylar fractures, those are the most common there in our kids. Those are also really associated with a lot of our Fourche-type injuries. We also see those a lot with a lot of playground injuries, monkey bars, swings, and they cause that blunt trauma-type injury. One thing that we can help us with these is actually doing our anterior humeral line test. And we can see here, if we line up this x-ray and we're looking at, if we line up the anterior humeral line, it should go through the middle third of the capitellum. So this tells me I've got nice normal anatomy, nothing here has been displaced. So that really helps me look for those occult injuries. So let's put that over an x-ray. Anterior line goes straight through the middle of the capitellum. There's no displacement there. It gives me that nice clean 90 degrees. Doubtful there's anything there that I can't see that's occult. But let's see what happens when we actually see this in an injury and look there. There's my humeral line, and it does not go through the middle third. It actually goes to the anterior third. And this one pretty easy stands out because it's displaced, but also got that huge posterior fat pad as well. So look for those. Sometimes those fractures can be very subtle, but we look for other things that tell us that, like the fat pad, or hey, that doesn't have that nice normal 90-degree turn that it's supposed to have. So it's kind of a table to kind of help you with these elbow injuries, pediatric versus adult things to consider. As I mentioned, fat pads may be helpful or may not. All posterior fat pads are abnormal. We don't see them that much in adults, but sometimes it's occasionally there, and you're like, oh, look, there's a pretty little fat pad sticking out. But I can look closer, and now that most of us have electronic, we can really magnify these images, and you can get down there and say, well, there it is, or reverse your contrast and be able to look for those. But if in doubt, talk to your experts. Get that overread. I love being able to have my overreads every day. If I don't have that, I'm in a low-resource area. Most of these patients are going to be totally appropriate to immobilize them, whether that's a splint and a sling, and then have them follow back up for recheck, or maybe bring them back and re-image them in another week, and that's when you'll start seeing changes from that healing. Epicondylar fracture is also very common there in our pediatric patients. This uses the Gartland classification system. Usually the more minor the injury is, usually less severe treatment, but if they get up to the class 3, class 4, those almost require operative intervention as well. These definitely may involve some Salter-Harris type injuries we'll talk about in just a moment. They're involved in the growth plate. The big thing about these is we don't usually see fat pad signs. So I can look at the bones. What do I see? How is their movement? And definitely if I'm in doubt and this person has pain with range of motion, or especially if they have point tenderness in one specific area, look at that really closely. If I am concerned, always appropriate for them to follow up for repeat imaging in a week or two, or at least to have good follow-up care. So our growth plates. And our mnemonic here is crito. And if we haven't looked at a lot of pediatric films, these can sometimes be confusing. I know when I started out and I'm looking like, oh, look at all, oh, wait, no, that's not a fracture. So typically if it's nice and smooth and it looks very even, those tend to be our growth plates. Most of your fractures are going to have some irregularity to them, whether it's some jaggedness or some offset to that center of that line, but look for those. And typically here by crito, we start closing from age 1 all the way up. But this is when the comparison views may be also very helpful. If I have that, get an x-ray of both those extremities and look at them. Do they look almost identical? Then that's probably their growth plate. Or sometimes it's a normal variant that we hear about, and it's not actually a fracture. But what do we see on clinical exam? How is their range of motion? Do they have full range of motion with a little bit of pain? Okay. Or they have very limited range of motion because they have so much pain, and those are definitely the ones that I'm more concerned about. We talk about dislocations. We talked about shoulder dislocations earlier. P's is my mnemonic here. Elbows are almost posterior, and shoulders are almost always anterior. So posterior elbow, anterior shoulder, P's. But we see these a lot with those Fuchs-type injuries as well. They fall in that outstretched hand. They get that blunt trauma that forces that out of its space. Very painful, limited range of motion. Just like with shoulders, talk about knees and stuff later, we have to worry about that risk for neurovascular injury. Elbows do have a high risk for injury of the brachial artery because when we displace that structure, move it out of its normal joint space, we definitely can tear or put more tension on those vessels. On these, they're usually pretty easy to reduce. There's still the debate, do I image them before, I image them after, I do both. Most are going to probably reduce these and then image them later just to make sure there's no occult fracture. If I'm really concerned about a fracture initially, that might be a reason I might want to image before I reduce it. Otherwise, let's reduce it sooner versus later to reduce that risk of neurovascular injury, and then let's just image it later after the reduction for resolution of that, plus to make sure there's no fracture underlying structures. Most of these patients with a simple dislocation, all they need is a sling for a couple of days. They don't need any more mobilization because most of these people, once I get them reduced, I'm going to limit their movement for a day or two, but then really start doing some normal range of motion activities just to strengthen that area and keep it from being at high risk for further injury. Olecranon bursitis, one of our overuse things that we'll sometimes see. These usually are not associated with anything penetrating to that joint space or to that olecranon sac itself, but occasionally we'll run into that. But this is seen a lot with people that do a lot of work and they're down on their elbows, so carpet layers. People do a lot of manual labor and they're moving around on their elbows. Students, sometimes they spend a lot of time on their stomach studying and reading, but they've got irritation there in that area. This guy here has a nice little bursitis going on. Just that bursal sac gets inflamed. Maybe it's very swollen, very tender. If it's very red or very hot to the touch, then I'm more concerned about this could be infectious. So can I get a history? Was there concern they might have a penetration injury? They were crawling around and felt something like it stuck them there. Then we'll sometimes find a foreign body there. But for the most part, imaging here isn't helpful. Sometimes if you do image them, you might see that little calcium deposit there as that sac has become just constantly inflamed and has a little calcification to it. But treatment here usually is just very supportive. We can try NSAIDs, we might have to go to steroids, but most of these require nothing else than supportive care. If we are concerned about infection, if it's really red, it's really swollen, really tender, this might benefit from actually doing a gram stain, actually anesthetizing that area, drawing out some bursal fluid and sending it off for culture just to see if it is. Typically, it's our usual pathogens, our skin stuff, so staph and strep. Occasionally, we're now seeing some more things with MRSA as well. But typically treat those pathogens if we're worried about that. These might benefit from injection of a local anesthetic plus or minus some corticosteroids. But there's no infection, it's purely supportive care. Looking at a couple of the studies that actually doing the anti-inflammatory injection with some corticosteroids may help improvement, but overall there's really no change in course. So those can be kind of painful. So depending on your practice, depending on your patients, they may or may not benefit from that, but using their supportive oral therapies just as well. So we can see here this nice non-inflamed there on your right versus that red inflamed that we see there on the left. And there's just that x-ray image showing that little calcification. Usually, unless I'm really worried about some type of foreign object getting stuck up in there, there's really no need for imaging. But if you definitely had that history that makes you concerning, go and look for that. Maybe they have a little tack or a little something that got stuck up in that area, and that's what's caused the inflammation and, sometimes the infection. So our nursemaids, definitely our most common subluxation we run into. The old adage, typically the kid got pulled up by the arm and it caused a slight little dislocation there of the radial head. It kind of slips out of that space. This is very common, 1, 2, 3-year-olds. Usually by age 5, that ligament's more strong and more sturdy, and this is less likely to happen. Classic presentation is the kid comes in, they're neglecting that arm, they're not using it, they have pain with movement, pain with any type of range of motion with it. Treatment is usually very simple, usually does not require any imaging unless I'm worried about something else. So try to get a good history. Did something grab that kid by the arm? Did someone grab it? Or they actually have blunt trauma and actually fell on it? Educate the parents. And in some scenarios, if we have to reduce this, the parents might be open to learning how to reduce it the next time on their own. But usually after about age 4, by age 5, their incidence is dramatically reduced. But just a little slight subluxation there of the radial head. That ligament gets stuck and gets caught out of place. Usually by age 5, it's nice and sturdy and strong and holds it right there in the right spot. For years, we would do that classic supination and flexion. That was pretty painful, but it worked. The whole goal there is to kind of hold your finger or your thumb right there over the radial head and feel for that click as you rotate. And probably looking at most of the studies now and probably for most of our practice, the hyperpronation technique as you see here tends to be as effective or more effective and probably is less painful. So to stabilize the joint, stabilize the radial head with your fingers or thumb and hold it, and then take their hand and hyperpronate it as you're supporting it, and you'll usually feel that click. And that usually results in almost improvement in their symptoms, and almost quickly they start using it. Most kids within 5 minutes are going to be using that arm very freely and back to normal. If you don't feel that click, then you may not have got that reduced. Try again. Typically, we won't do any imaging unless we don't get that click or they don't start using that pretty spontaneously or the history doesn't support a nursemaid. Maybe they had direct trauma to that area. So some other specific fractures we run into, these are pretty rare, the Monteggi fracture and the Galeazzi fracture. These involve a fracture and a dislocation. So MUGGER is our acronym here. These almost always require surgical intervention since they have a fracture and a dislocation. They're usually blunt force trauma. Probably less than 5% of our forearm injuries involve one of these two. But definitely if you see one of these, you've got the fracture and the dislocation, they have a higher incidence of a neurovascular injury as well. So I want to get orthopedics involved as soon as possible. If I need to reduce that dislocation, let's reduce it and let's immobilize it to prevent the risk of further neurovascular injury. But if you run across one of these, high-risk injury there, and again, this is that paired bone phenomenon. So if I see one injury, always look for the second injury because a lot of them will have both. Colles fracture, definitely some of our common forearm fractures we see. Again, almost always that Fuchs injury. To be a true Colles fracture, I've got to have fracture both of the distal radius and the ulnar styloid. So again, look for both those injuries. If there's one injury, there's commonly going to be two. Look both proximally and distal to make sure I've ruled those out. Occasionally we'll see just a radial fracture or just an ulnar fracture. But to be a classic textbook Colles, I've got to have both those fractures there. These usually reduce very well and usually recover very well. These can be done with procedural sedation. Sometimes these work really well with hematoma blocks if you're able to do those. You don't have to do procedural sedation. You just got to have time and equipment. But if I can go in there and do a hematoma block, inject that fracture site with some lidocaine or marcaine, let it set up very well, this patient may require nothing else, and we can reduce it pretty easily. So a Colles versus a Smith's. So that Colles fracture I mentioned, that's typically that outstretched hand, where a Smith's fracture is different. That's falling backwards on a flexed hand. And that tends to have a very similar mechanism, but a different injury pattern. So just get the history. What did actually happen? Did they fall and go straight forward? Or is it one of those where they landed backwards? And that's not a Colles, that's a reverse Colles, or sometimes referred to as a Smith's. So what do we see distally? Where's their range of motion? What's their movement? What's their sensation? How are those distal pulses? Again, if I see one injury, always look for the other one, because a lot of times if they have one injury, they'll have two. If they've got a significant interarticular fracture, that's definitely something we want to make sure orthopedics involved. If it's got a base fracture there at the end plates, we want to get ortho involved sooner versus later. We want to definitely make sure they have good resolution and good healing for those kids so it doesn't impair bone growth. If they're on that Salter-Harris frequency, what is it? And make sure orthopedics knows, hey, this actually is a Salter-Harris 1 or 2, so they have close follow-up. So where are we at with that growth plate? Is it nice just that right there, just a little bit of a slip, or is it straight, or is it above, or is it low, or is it through both, or is it that ram type injury? So whether it's the wrist, a forearm, it's the other joints, what's that classification? I have to look these up. I don't remember them. So most of the time, radiologists are really good at telling me what it is, but ortho wants to know what that is, especially if you're having to describe it to them versus giving them that picture. Most of us now have easy access to our digital, so we can look at it. Sometimes they want you to text it to them. That may or may not be HIPAA compliant based on your hospital policies. But how do they describe it? Where is it in that fracture? But definitely if it involves this joint, involves this growth plate, that needs closer follow-up and observations. We make sure we get proper healing so it doesn't impair bone growth with that kid. So our most common here is the Salter-Harris 2. As you can see, it's right there above the epiphysis, where that ram-type injury has more of that crush-type jamming injury, and then definitely that lower one there below the epiphysis. But all these are concerning for impairment of bone growth if it involves that growth plate. And then lastly are overuse syndromes. So if I've got this typical pain there with the lateral or the medial epicondylitis, usually from overgrowth, overuse, we're talking about tenderness or golfer's elbow. Usually they have that point tenderness, but also they have pain with certain movements or range of motion. And then whether they're rotating in or they're rotating out. Most of these patients, rest is really all they need. We can try anti-inflammatories. There are some devices, as you can see here, these splints that kind of put some compression on that. What we really need this patient to understand is this is from whatever activity they're doing. If they can modify how they do that activity, that tends to reduce the incidence of these problems. And then lastly, decurvans tenosynovitis. Get some pain and tenderness right here around the radial base. This sees a lot, especially with pregnancy, because of water gain that we'll sometimes see. And the classic thing is we'll do the Finkelstein test. We want them to do some ulnar deviation, as you see here in this picture. And they do that ulnar deviation. It gives them increased pain. And if you can, feel and palpate over that area. And a lot of times as they do that ulnar deviation, you'll feel some crepitus. And that's just inflammation there of that tendon sheath. This can be supported usually with some immobilization devices, but definitely may be beneficial for rest and some NSAIDs as well. See it a lot, as I mentioned, in pregnancy. That usually goes away after delivery, but definitely this is just some of our common overuse syndromes. If patients can understand why they have it, they can modify their activities. That tends to reduce the incidence and hopefully the severity. But definitely they have more of these problems. Trying to get them in to see hand or whatever specially manages those may be able to do some other options. All right, thank you very much.